Ventricular tachycardia, an overview. Ventricular tachycardia, VT, is a potentially life-threatening arrhythmia originating from the ventricles of the heart. It is characterized by a rapid heart rate, 100 beats per minute, and originates below the atrioventricular AV node, specifically in the ventricular myocardium or his Purkinje system. Let's delve into this condition step by step, from basic concepts to more complex clinical considerations. 1. The basics of the cardiac electrical system. To understand VT, we must first review how the heart generates and propagates electrical signals. Normal conduction pathway, SA node, the sinoatrial SA node in the right atrium, is the heart's natural pacemaker, initiating impulses at 60 to 100 BPM. AV node, impulses travel through the AV node, which acts as a gatekeeper, delaying the signal to allow ventricular filling. His Purkinje system, the impulse travels through the bundle of his, bundle branches, and Purkinje fibers, stimulating ventricular contraction. Ectopic foci. In VT, abnormal electrical signals arise from ectopic foci within the ventricles, bypassing the SA node. 2. What is ventricular tachycardia? Definition. VT is defined as 3 or more consecutive ventricular beats at a rate 100 BPM. Classification. Duration. Non-sustained lasts 30 seconds. Sustained VT lasts 30 seconds or requires intervention due to hemodynamic instability. Morphology. Monomorphic VT, consistent QRS morphology. Polymorphic VT, variable QRS morphology, e.g. Torsades de Pointes. Mechanisms behind VT. The mechanisms leading to VT include re-entry, the most common mechanism, where electrical impulses circulate in a loop due to areas of slow conduction and unidirectional block. Example, post-myocardial infarction scar tissue creates reentrant circuits. 2. Triggered activity, abnormal depolarizations during or after repolarization. Example, early after depolarizations in Torsades de Pointes. 3. Abnormal automaticity, ectopic pacemaker activity from ventricular cells. Example, ischemia-induced automaticity. Clinical manifestations, symptoms. Palpitations, dizziness or syncope due to decreased cardiac output, chest pain, dyspnea, sudden cardiac arrest in severe cases. Hemodynamic consequences, rapid ventricular rates, reduced diastolic filling time, leading to decreased stroke volume and cardiac output. Sustained VT can lead to cardiogenic shock or progression to ventricular fibrillation, a more chaotic and lethal rhythm. Etiology of VT heart disease, myocardial infarction most common, dilated or hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy ARVC, non-structural causes, long QT syndrome or Brugada syndrome, electrolyte imbalances e.g. hypokalemia, hypomagnesemia, drug-induced e.g. antiarrhythmic drugs, QT prolonging medications, other, myocarditis post-cardiac surgery. 6. Diagnosis electrocardiogram, wide QRS complexes, 120 milliseconds, regular or irregular rhythm depending on VT type, absence of preceding P waves or AV dissociation, capture beats or fusion beats, specific for VT. Holter monitor for detection of non-sustained VT. Echocardiography to assess structural abnormalities. Electrophysiology study, EPS, for precise localization of arrhythmogenic foci. Clinical correlation and rationale. Acute management of VT. 1. Hemodynamically stable VT, antiarrhythmic drugs. First line, amiodarone, procainamide, or lidocaine. Consider synchronized cardioversion if pharmacologic treatment fails. 2. Hemodynamically unstable VT, immediate synchronized cardioversion. Follow up with antiarrhythmics to prevent recurrence. 3. Torsades de Pointes, a subtype of polymorphic VT. Correct underlying causes, e.g. hypokalemia, hypomagnesemia, magnesium sulfate infusion, overdrive pacing or isoproterenol for refractory cases. Long-term management. 1. Preventing recurrence. Implantable cardioverter defibrillator, ICD, indicated for high-risk patients, e.g. post-MI with reduced ejection fraction. Antiarrhythmic drugs, amiodarone or beta blockers. Catheter ablation for focal VT or recurrent episodes. 2. Risk stratification. Assess ejection fraction, presence of scar tissue, and underlying cardiac disease. 3. Lifestyle modifications, avoiding stimulants, e.g. caffeine, alcohol. Treating comorbidities like hypertension or coronary artery disease. 8. Advanced considerations. VT in special populations. Post-MI VT, Scar-related reentry is common, requires close monitoring. Idiopathic VT, seen in patients without structural heart disease, often originating from the right ventricular outflow tract, RVOT. Differential diagnosis: supraventricular tachycardia, SVT, with aberrant conduction can mimic VT. Clinical and ECG clues, e.g. AV dissociation, help differentiate them. Conclusion: ventricular tachycardia is a complex arrhythmia with a spectrum of presentations, ranging from asymptomatic runs to life-threatening events. A thorough understanding of its mechanisms, clinical implications, and management strategies is crucial for optimizing patient outcomes. Early diagnosis and tailored therapy are key to reducing morbidity and mortality associated with VT.